Good afternoon. My name is Dr. Daniel LaRoche. I want to thank Dr. Joe Alansi and the organizers for inviting me to present this talk. I want to congratulate the residents at the University Hospital on pursuing ophthalmology. Today, I want to talk to you about new and affordable surgical approaches to glaucoma surgery to prevent blindness and in many cases cure glaucoma. Glaucoma is a leading cause of irreversible blindness in the world with an estimated global burden of over 64 million people. It's projected to increase to about 111 million people by 2040. Currently, the only modifiable risk factor for glaucoma is intraocular pressure, and lowering intraocular pressure is the mainstay of treatment to date. Now, the mean normal intraocular pressure is 15, not 21. The mean normal is 15. And then the mean intraocular pressure of patients with glaucoma is 18, not 21. So when I see someone that has a pressure of 18 or higher, I look very carefully for signs of glaucoma. Okay? Elevated intraocular pressure leads to both mechanical and vascular damage to the optic nerve. You can see here there's damage to the optic nerve, there's a disc hemorrhage, loss of nerve fiber and the extubation of the optic nerve. When I was training back in 1994-96, I used to treat glaucoma with medications first, then laser, then trabeculectomy, and subconjunctival tube shots. That has completely changed for me with new treatments for glaucoma. Why do people still go blind to glaucoma? Well, in my opinion, I think we're not treating glaucoma properly. Glaucoma is not properly being treated. We know that with medications with early manifest glaucoma treatment, with lowering intraocular pressure from 25%, you can slow glaucoma down to people still get hours. And you can see that people in treatment with high glaucoma can still get hours. We know that there's not compliance that can occur. It could be as high as 50% of one medication, 61% of two medications, 70% of medication. In 1994, Roger Hitchens did a study that showed that earlier surgery could be better in laser and medicines with visual field preservation. It showed that primary surgeries that can be the lowest mean intraocular pressures and visual field intraocular material in patients with both medicine and to a lesser extent laser group, but not in patients with the surgery treated. So with surgery, you can stop visual field progression in the study. We also know through the prestigious study from Paul Richter that people who have surgery do better than people with medications, and particularly people with advanced glaucoma, -8. And many Black patients in Haiti, in the United States, and Africa present with more advanced rate of glaucoma, and surgery does better to preserve the visual field in these patients. What causes glaucoma in persons over the age of 50? Well, the main cause that I have seen because of glaucoma is the increase in lens thickness. You can see here with age, the lens increases in size. And this lens thickness contributes to glaucoma, and I'll show you how as it increases with age. You can see here the lens can increase by about 30% with age. And you can also see that in patients over 50, the prevalence of cataracts increases, okay, from 50 to 60 to 70, the increased number of cataracts that occur with age. And the same thing happens with glaucoma. Around age 50, the prevalence of glaucoma starts to increase in all parts of the world, Asia, Africa, Europe, North America, Latin America, and in all ethnic groups, Europeans, Africans, Hispanic, and Asians. I'm going to show you how the increased lens contributes to glaucoma.
Leading cause of blindness, globally affecting nearly 80 million people by 2020. This silent thief of sight involves optic nerve damage and visual field loss secondary to retinal ganglion cell damage or cell death. The eye produces fluid from the ciliary processes to bathe the eye. The fluid drains via the trabecular meshwork, aqueous veins, uveo-scleral pathway, and suprachoroidal space. With time, the trabecular meshwork ages and the lens of the eye becomes larger, developing a cataract. This narrows the drainage angle, reducing the ability of aqueous to drain from the eye. Additionally, in some patients, the zonules that attach the lens to the iris rub against the posterior iris, releasing pigment that further blocks the outflow pathway. This, in addition to genetic predisposition in some patients, leads to elevated intraocular pressure. This increased pressure goes on to damage the optic nerve, described as cupping. When this occurs, medical therapy should be initiated. Since as many as 50% of patients fail medical eye drop therapy, early cataract extraction can be performed to open the angle, and goniotomy should be performed to remove the damaged trabecular meshwork to help improve aqueous flow. Patients with advanced glaucoma due to worsening outflow will need an additional intervention.
So that's the mechanism that I see in my practice of what causes glaucoma. So my approach has changed to an earlier surgical approach by doing early cataract surgery and open up the drain. When I do that, about 80% of people do not even need eye drops thereafter, and you can cure glaucoma if you catch it early enough. Here's the outflow system of the uveal meshwork, corneoscleral meshwork, just the canalicular meshwork, and Schlemm's canal over here. You have to get through all these layers that get blocked to Schlemm's canal, okay, to help restore outflow that gets blocked from a large cataract and or pigment that blocks this area. You can see here Schlemm's canal decreases in size with age, okay? From age 8 to 34 to 48 to 75, the canal gets smaller. In part, that's because of the lens getting larger, okay? And you can see here, why did the trabecular meshwork and Schlemm's canal get smaller? The cataract that starts to get larger, usually by age 50 years of age. How else does an enlarging lens contribute to the cataract? Well, like the video showed, you see these lens annuals here? Here you have the lens annuals, and here you see lens annuals over here, and it rubs up against the iris over here. You see the iris and the large lens here? There's rubbing of the iris against the large lens. And you can see here in a video from Dr. Gold, a video from Dr. Gold,
in the lens thickness. The anterior lens capsule moves forward, and the posterior lens capsule moves backward. More importantly, the anterior capsule steepens centrally, comprising the largest element of the refractive change during accommodation. Other significant findings are posterior bowing of the iris in the mid-periphery. At the same time,
you can see in this video by Dr. Gold, this lens during accommodation gets larger. It rubs up against the iris over here. There's posterior bowing of the iris and rubbing over here, okay? You can see that in this video from Dr. Gold. This is what happens during accommodation. And so with that, you have rubbing of the lens and the iris over here. And you can see the pigment that's rubbing off, okay? And in this pigment that's rubbing off, when you see these things here, it can block the trabecular meshwork. You see this pigment that's blocking the trabecular meshwork? You have to look with this with gonioscopy. That's why gonioscopy is very important. You've got, every glaucoma patient should have gonioscopy to look at the angle to see if you can see it. Is the iris blocking it? Is it angle closure? Is it pigment obstruction? The majority of my patients have some component of that. I'd say 80 to 90% of my patients with glaucoma have something like that. And so I schedule them for surgery, I take the cataract out, and I open up the drain. You can see here pigment obstruction of the trabecular meshwork. Now, this is a normal activity of the Schlemm's canal, trabecular meshwork here. And with the cardiac cycle, as the heart pumps, the canal pumps. And you'll see here aqueous outflow, Schlemm's canal pumping and aqueous outflow taking place. This is a normal canal, and this is what you want to preserve. Now, what happens in glaucoma? You have blockage of the trabecular meshwork and decreased pumping of Schlemm's canal. And in more advanced glaucoma, you have diffuse blocking, thickening of the trabecular meshwork, and much smaller and decreased pumping of Schlemm's canal. And you want to prevent this. And we can prevent this with earlier cataract surgery and trabecular bypass surgery. Now, if you do trabeculectomy, which is what I used to do first, the problem is that if you've not taken out the cataract or removed the lens will continue to rub up against the iris, and then pigment will release, and pigment will block off your trabeculectomy. So I do cataract extraction first and angle surgery before I do trabeculectomy. And most of those patients, if you do it early enough, will not need a trabeculectomy. Now, what happens when you take the cataract out? Here's the lens, okay? And sometimes I'll do clear lensectomy also. Here you take the cataract out, you put an implant in. The angle is much more open, okay? You can get a 5-point drop in pressure from patients with primary open-angle glaucoma, okay? And you have no more lens iris rubbing here. There's no more lens iris rubbing taking place. And Schlemm's canal expands. You can see here Schlemm's canal gets bigger, okay, by 2 to 4 times, okay? You have an expansion of Schlemm's canal once you take this large lens out. And with the increasing size of the lens and narrowing of the angle, you get much more opening of the angle as well. And we know from many studies that cataract surgery alone can lower intraocular pressure from 13 to 71%. If you have angle closure, it lowers the pressure more compared to primary open-angle glaucoma. Some studies show it goes from about 13% to as high as 71%. Now here's a video of a patient that did cataract surgery alone. I'm putting BSS in the eye. Look at this vessel. This vessel, you'll see blanching, aqueous outflow through the vessel. And this was just from cataract surgery alone, no glaucoma surgery. So you can see through these, just by taking the cataract out and putting BSS in there, you have improved aqueous outflow and lowering of the intraocular pressure. And in the Hydra study, which is a study that looked at cataract surgery and the Hydra stent, okay, that lowered the pressure very well, okay, dramatic amount, 10 points here in this study. But look what cataract surgery alone did. Cataract surgery alone lowered it. It's about 7 points in this particular study as well. So cataract surgery is very powerful to lower intraocular pressure. And studies have shown from England and Taiwan that with the increased prevalence of phacoemulsification, you have a decrease in angle closure. So by taking these cataracts out earlier, you can reduce the incidence of angle closure in the population as well. And here in the EAGLE study, it showed that clear lensectomy, clear extraction showed greater efficacy and was more cost effective than laser peripheral iridotomy, okay? So I don't even do laser iridotomies anymore. If someone has angle closure, occludable angles, narrow angles, I just offer them cataract surgery or lensectomy, clear lensectomy, because that will resolve the problem. That will permanently treat the problem. I don't have to monitor them every 3 or 4 months to look to see if the angle's getting narrower or if things are getting worse. And then also, that can exacerbate the lens iris rubbing that can continue as well. Now, cataract surgery is not without risks. Okay, when you do cataract surgery, you can get suprachoroidal hemorrhage, endophthalmitis, retinal detachment, CME, corneal endothelial loss, elevated IOP, dysphotopsia, incorrect IOL power. So you have to do cataract surgery very, very good. So for the residents, the challenge is to learn how to do excellent cataract surgery so that you can improve people's vision and lower their eye pressure, okay? If you're not doing good cataract surgery, then you don't want to do this because you're going to create complications and make the patient's vision worse. Now in the United States, cataract surgery is a very successful procedure, and there are low-cost techniques to do very successful cataract surgery that I'll show you as well. Now, when it comes to glaucoma surgery, there's a variety of different glaucoma surgeries you can do in devices. In the United States, I like to use the Hydra stent. If I'm international in Haiti or Caribbean or Africa, where this may not be affordable, I'll use a 23-gauge cystotome and Sinskey hook, and I'll show you that. You do have to have a microscope that tilts, okay, that tilts about 45 degrees. I rotate the patient's head 45 degrees. I have a gonio lens here so I can see the angle, okay, and then be prepared to do angle surgery after cataract surgery. Now, what about SLT? SLT does do better than medical therapy to slow down visual field progression, but you still get progression that can occur, okay? And so it's not as effective as well as patients on combination medical therapy. So I'm not a big fan of SLT. I prefer to do the surgery first instead of SLT. And this is a study that looked at the Hydrus microstent compared to SLT. And in both groups, there was significant lowering of the intraocular pressure, but with the Hydrus group, there was a 3-fold greater reduction in medication use compared to SLT. So Hydrus did much better than SLT. We previously reported the use of trypan blue that can be used to visualize the pathways and canals and aqueous veins to look at the outflow in patients with glaucoma. And here's using the Cahook blade. You see, here's a trabecular meshwork. You have a gonio lens, and I'm going to unroof the trabecular meshwork, expose the back wall of Schlemm's canal with the Cahook blade here, okay? This blade is used a lot in the United States. It's about $450 though, so it's very expensive, okay? I'm going to show you a low cost where you can do it in Haiti as well. And here you see blood reflux. That's normal blood reflux you see from the aqueous veins. And you do this after cataract surgery. And look at these vessels here. I put BSS in the eye, and these vessels are blanching, okay? You see this vessel here is blanching as I put the BSS on and off right there. That shows I've connected, restored the aqueous outflow via the natural pathway. And this is what you'll see after goniotomy here, okay? And that works really well to lower the intraocular pressure on less medications. It works better than the eye stent as well. Now, is there a low-cost way of doing this? In Haiti, for example, where people can't afford $450 for gonio lens and the hook blade? Well, first you have to do manual small incision cataract surgery. Let me show you this.
This section. So you can see I have first created a groove that is about half thickness deep, and then I create a plane in that groove that will allow me to dissect forward. The dissection up to the sclera is carried out following the scleral curvature, but at the limbus, in order to follow the corneal curvature, the plane is angled up further. A side port in the horizontal quadrant allows a rexus to be carried out easily and also gives access to the sub-SICS tunnel for cortex aspiration. It also allows access into the anterior chamber for all maneuvers to be carried out in a closed chamber manner. A larger than normal rexus is made to allow prolapsing the nucleus out, and as you can see, I have also made 2 or 3 relaxing incisions in the superior rexus. A horizontal entry is then made into the anterior chamber all along the length of the tunnel, and the internal lip, as you can see, is larger than the external lip. Hydrodissection is then done to collapse one pole of the nucleus out, and viscoelastic is injected both below and above the nucleus in order to protect the endothelium. Once this is done, the nucleus is dialed out to bring it out into the anterior chamber. The superior rectus brittle suture is pulled slightly upwards while at the same time injecting viscoelastic under the nucleus, and this allows the nucleus to be brought out through the corneoscleral tunnel. Sutures are then taken and the viscoelastic is washed out. Cortex aspiration is then done through the side port, maintaining a formed anterior chamber, and this is the advantage of the side port. It also allows you access to the sub-tunnel cortex very easily. The relaxing incisions made in the rexus can be seen clearly here. Now, viscoelastic is again filled in the anterior chamber, and the IOL is inserted. It can just be placed into the bag, and the trailing haptic can be dialed in using a dialer. The side port again allows good maintenance of the anterior chamber during these maneuvers. Viscoelastic is finally removed using the simple cannula, and stromal hydration of the side port is done using VSS. It's easy to close the connector over the tunnel by cauterizing the edges together. As you can see, small incision cataract surgery gives very good results and a very clear cornea, even brown cataract.
So that was from Dr. Susan Jacob. And in Nigeria, they're doing this for $25. So it's a very inexpensive way to do cataract surgery. And at the end of this cataract surgery, you could also do angle surgery with a new low-cost effective technique that we reported using the 23-gauge straight cystotome to perform goniotomy. This makes micro-invasive glaucoma surgery accessible to the Africans and to the diaspora. And you can see a Katina makes a disposable lens. A box of 10 is about $250. These are $25 each. This is Eagle Labs, a 23-gauge cystotome. A box of 10 is about $40. You can get a 21 or 23-gauge straight 25-millimeter cystotome. Okay, I use a 23. You can also use a 25 as well. And you can order from Louise Singer at lsinger@eaglelabs.com. I like to use a 23-gauge cystotome. And this is what the tip looks like over here. Okay. And you can see here, I'm performing goniotomy, unroofing. This is a $4 cystotome. You can do the same thing as the hook blade goniotomy with a $4 cystotome. And you'll see here I'm using a cystotome, a $4 cystotome here. And I'm going to perform goniotomy. This is after cataract surgery with the disposable lens. And I'm unroofing the trabecular meshwork here, exposing the back wall of Schlemm's canal. This is a patient that has a failed trabeculectomy. You can see the iridectomy to the right. Now I'm going to go in with the Sinskey hook. And with the Sinskey hook, you can also unroof the trabecular meshwork. And this is another technique you can use. You see blood reflux there. I'm going in with the Sinskey hook. And I'm just unroofing the trabecular meshwork there. You see blood reflux there. You see the collector channels exposed. And you can accomplish the same thing. And you can see here, when you put BSS in, it blanches these vessels, and you get restoration of outflow here. There was a group at WashU that did a study looking at 25-gauge needle that's bent in 21 patients, and the average pre-op IOP was 17.8. And on 1.6 topical medications, and at 6 months post-op it was 14 on 1.6 medications. So you can get a nice almost 4-point lowering with this technique of using the bent needle goniotomy here. We taught this technique in Ethiopia with Dr. Addis Adaba and Dr. Georges, Jonathan Pons in Swaziland. He had excellent results using these cystotomes. It worked like a hook. Instead of paying $450, they can get it for $4 and use it. Another technique I want to show you now is the ciliary sulcus suprachoroidal microtube technique. This is a technique that I'll use in more advanced patients if they fail. Suprachoroidal implants in this study include the CyPass that was taken off the market because it caused corneal edema, the Supra, the Gold Shunt. This is a technique where you use a sterile silicone tube and you place it beneath a scleral flap into the ciliary sulcus to the suprachoroidal space that works well to lower the intraocular pressure. The suprachoroidal space is a robust pressure gradient, works well to lower the intraocular pressure. You see here. When we did our initial series, the average intraocular pressure reduction was 36% at 3 months. The amount of glaucoma medications at 3 months dropped from an average of 3 to 0.25. And I used a tube extender in the United States. It's about $125, okay, using a tube extender.
Dr. Daniel
And
LaRoche
this is how it
is a
works.
board-certified ophthalmologist and glaucoma specialist and president of Advanced Eye Care of New York. He is a graduate of New York University and Cornell University Medical College and inventor of the intrascleral ciliary sulcus suprachoroidal microtube technique, a surgical treatment for glaucoma. This microtube shunt procedure should only be used in patients with glaucoma whom have had their cataracts removed. This procedure allows aqueous fluid to safely drain to the suprachoroidal space without the risk of corneal edema, which can occur when a tube is placed in the anterior chamber. Under local anesthesia, an infratemporal conjunctival opening is made to place the microtube in this quadrant. A small partial thickness scleral flap is made to place the tube. A micro-opening is made superiorly to place a viscoelastic gel into the eye to expand the space between the posterior iris and the intraocular lens. This is where the silicone microtube will be positioned. A small 23-gauge needle is used to make an incision into the ciliary sulcus. Then the silicone microtube is placed. The position is confirmed with a second instrument. The microtube is then tied to the eye. Then another micro-opening is made to access the suprachoroidal space. The posterior end of the tube is inserted into the suprachoroidal space. This connection allows the aqueous to drain to the suprachoroidal space. This bypasses the damaged trabecular meshwork to successfully lower intraocular pressure. The scleral flap is then sutured closed. The viscoelastic gel is left in the anterior chamber. Post-operative steroids and antibiotics should be given. Dr. LaRoche has had excellent results lowering the intraocular pressure. Since glaucoma is a lifelong disease that can worsen with age, a patient's intraocular pressure should still be checked periodically. Additional medical therapy or repeat surgery may be needed. Diet, exercise, and mindfulness are important aspects for glaucoma care as well. So, in our initial series of 12 months follow-up, we had 26 patients, 18 with moderate to advanced glaucoma, and Sukafika was successful at 12 months. The mean pre-op IOP was 21 on 4.2 medications. The mean post-IOP was 12 on 2.4 medications. The risk of benefits are the same as traditional glaucoma surgery. There were some patients that had blocked tubes that needed laser iridotomy to lower the intraocular pressure. One tube was inserted behind the intraocular lens. 2 required needle revision, and 4 patients needed additional surgery to control intraocular pressure. You do get transient hypotony for the first week, but this is an inexpensive way to offer your patients access to the suprachoroidal drainage system. And you can use an Aurolab tube. Aurolab makes a tube that's about $50, and you can use the silicone tubing from the Aurolab tube to do this procedure. And this is a poster that we're presenting at the American Glaucoma Society this upcoming year that shows the results that we had from 21 to 13 in terms of lowering intraocular pressure, and from 4.2 to 2.4 medications at 1 year follow-up, okay? Intrascleral ciliary sulcus suprachoroidal microtechnique safely lowers intraocular pressure and medication burden.
but surveillance is required because you can get pressures with IOP spikes and scarring of the suprachoroidal space that can occur. Okay. Here you can see the tube into the ciliary sulcus to the suprachoroidal space. Ultrasound by microscope, the tube to the ciliary sulcus to the suprachoroidal space. Here's a tube in the ciliary sulcus. Here is aqueous pooling in the suprachoroidal space. And here another one, tube in the ciliary sulcus to the suprachoroidal space. Here's a tube that was blocked by the iris, and we did laser iridotomy to reopen the tube here to remove the blockage. And here's another patient with a tube in the suprachoroidal space with aqueous pooling in the suprachoroidal space here. But now what I do to enhance the success rate of the procedure, I do a combination goniotomy and suprachoroidal microtube technique. And so far we have 6 patients that were pseudophakic with advanced glaucoma. And the mean pre-op IOP was 21 and 4.3 medications, and at 6 months the mean post-op IOP was 13.5 and 0.83 medications. There are no serious complications, no bleb, and the risk of benefits are similar to traditional glaucoma surgery. So I combined the two, goniotomy and angle surgery and a suprachoroidal microtube technique. And we published this in the Indian Journal of Ophthalmology, our initial series. And here's a video that describes this technique here. Okay, here I'm going to perform the goniotomy with a 23 gauge cystotome. And with the cystotome, you can refill the eye with Healon. Here's a Sinskey hook I'm using to open up the right side of the angle and expose the back wall of Schlimm's canal. And so I have a nice goniotomy that I've done. Okay. I'm going to place a 10-0 nylon suture here. I'm going to suture the wound close. And now I'm going to perform a suprachoroidal microtube technique here. Here's a clot forceps, Westcott scissors. And I'm going to give some anesthetic here. And perform a conjunctival peritomy. Here's lidocaine with epinephrine and marcaine, 0.75% mix and a 50-50 mixture. And I'm giving a peribubble block because they can't feel the dissection. I've performed the conjunctival peritomy inferior-temporally. This is inferiorly and temporally. I pass an atovicral suture here. There's going to be a retraction suture to give me exposure. This is 0.12 forceps in a crescent blade. And this is about a 4 millimeter by 4 millimeter scleral flap. And I'm going to do a dissection of the scleral flap here. Here's a 15 blade. I make a paracentesis. And I'm going to inject viscoelastic to deepen the anterior chamber and create a space between the iris and the lens in the ciliary sulcus here. Like an endocoat type of viscoelastic, a thick viscoelastic I like to use here. Here I'm just hitting the lens and repositioning the lens a little bit more, breaking up some of the fibrosis there, and placing a viscoelastic behind the iris in front of the lens. The eye is dilated for this procedure. Here's a tube extender, and I'm cutting the tube here with a bevel. With a 23 gauge needle, I make an incision 2 millimeters from the limbus behind the iris into the ciliary sulcus here. And now I'm going to insert the tube with the bevel facing the intraocular lens, bevel down. into the ciliary sulcus. Okay, then I pull it out a little bit because I don't want it to be in the visual axis. And I'm going to tie through the tube to the sclera with a 10-0 Prolene suture here. So I tie through the tube. Okay, and I tie it. Therefore, the tube does not move. And Prolene is a long-lasting suture. Then I make an incision into the suprachoroidal space about 2 millimeters back from there. I make with the crescent blade, I do a gentle dissection by feel until I feel the space. Okay, and there you go. You see the suprachoroidal space. I've never had a suprachoroidal hemorrhage. I just do a gentle dissection. I make an incision here by cutting the tube there 2 millimeters back, flush, and then I insert the tube into the suprachoroidal space. And I've never had any bleeding from here. It's a spongy suprachoroidal tissue. There's a real space that's there, 30 microns. And then I close the scleral flap with 2 interrupted atovicral sutures, and I close the conjunctiva with interrupted atovicral sutures in a running locking manner. And then when done, you see the tube in the ciliary sulcus here. So here you see the tube in the patient post-dilation here in the ciliary sulcus. And this was a patient that had osteogenesis imperfecta. We actually placed a corneal patch because they had a very thin sclera, but normally I don't need to put any corneal patch or anything like that. Just the regular sclera is fine. We taught this technique in Nigeria with Dr. Donagunro, in Haiti with Dr. De Castro, and Dr. Mangret when I was there a couple of years ago. With this team, we did this procedure. And so in a CyPath study, 83% of patients did not need trabeculectomy. So could this be the same with this suprachoroidal technique or the combined goniotomy suprachoroidal technique? So we'll see what happens with time. So cataract surgery and angle surgery performed early in glaucoma can help really cure and decrease rates of blindness with glaucoma and avoid the complication of subconjunctival filtering surgery. And the supraciliary space, because of its anatomical and physiological characteristics, is an alternative and suitable pathway that can be exploited by glaucoma surgeons, but further research is still required. Now I'm going to talk to you a little bit about trabeculectomy. And I really have to do this. I mean, in the last 2 years, I think I've done 1 trabeculectomy because I do all this other stuff first. But basically, it's indicating people who have failed maximum medical therapy, and we have to lower the intraocular pressure. And when you're dealing with this, you have to talk about the risk and the benefits with the patient in terms of what the risks are. And the risk of trabeculectomy: risk of infection, risk of bleeding, risk of losing a couple lines of central vision. And that's why I like doing the cataract extraction and hydrogel, because we can actually improve the vision with that. It's very important to discuss this with the patients. And the patients often have to get a medical clearance to make sure that they're low risk for surgery. Their heart's okay to tolerate the surgery. And so you have to get the medical clearance from the medical doctor to make sure that they're okay. They do require intraoperative monitoring to measure the oxygen. Anesthesiologists and nurse anesthetists to make sure that they're breathing okay. You have oxygen to make sure that they're doing okay during the procedure as well. For trabeculectomy, you have to give either a block, okay? I like to give a local peribulbar block if they occur, but you'll need some sort of anesthesia to numb the eye. You're gonna have to do a prep, like a betadine prep, to really sterilize the eye, okay? And sometimes we give preoperative antibiotics as well. I like to use a lid speculum that keeps the eye forcibly open so that patients can't squeeze the speculums out of the eye during the procedure. You're gonna have to do a conjunctival perotomy, and this is a bridal suture that you can do also to pass through a stitch to retract the globe downward as well. Then once you do your conjunctival perotomy, you do a scleral flap, okay, with a 69 blade, and then you dissection 50% thickness of the scleral flap, and then you make an incision into the eye. First I'll do a paracentesis so you have access to the eye, then I'll make an incision, use a Kelly punch to remove some of the tissue here. And then I'll do a releasable suture technique where you pass a suture through the cornea, through the flap, and through the flap over here, the flap over here, and come out and do 4 throws, 1, 2, 3, 4, and tie it down. That's like a releasable suture that I'll show you. And you can do that same technique here. So that after the surgery, during the surgery, you can tie it down tight so you don't get hypotony. But then after the surgery, about post-week visit 2, you can remove the releasable suture to lower the eye pressure. And then you close the conjunctiva closed. And then you get a nice bleb at the end of the procedure. And here I'm going to show you a 6 trabeculectomy video where you can do combined trabeculectomy and extracapsular surgery as well. This is from the Advanced Eye Care Hospital in India. And you can do this in Haiti. This is a bridal suture. Okay, we have like a 6-0 nylon pass through the superior rectus muscle, and that gives you exposure. And here's a conjunctival peritomy. I usually do phaco trabs, but this is an extra cap trab. This is probably what's being more common. It's less expensive to do in Haiti. And you do cautery here. And then you're going to create a scleral flap, anywhere from 4 to 5 millimeters. And he's making a triangular flap. You could do a trapezoidal flap, but he's making a triangle. He's using mitomycin C, which is very important. If you can use mitomycin C, because you can't get scarring with these procedures, the mitomycin C reduces the scarring. You use 0.2, 0.4 milligram per ml and soak it for 2 to 4 minutes. Then you irrigate it profusely. And now he's doing a partial thickness scleral flap here into the clear cornea. And dissecting into the angle here. Making a paracentesis. Side port entry, putting viscoelastic in. Now he's using a keratome to cut into the eye. And extend the wound. Put viscoelastic into the eye here. Going to remove the cataract. Doing the capsulotomy. Here's removing the lens. So the large lens is removed through this incision here. Then he's going to wash out the cortex. It's important to get much of the cortex out. Put viscoelastic in the eye. Put the IOL in to the capsular bag. Then you do the Kelly punch here to remove corneal tissue and trabecular meshwork tissue. And you do an iridectomy to prevent obstruction of the ostium. And then here he's just suturing it with a regular suture. And he's using 3 throws here, 3-1-1. Here's another suture. And another suture. These are non-releasable sutures. I'll show you how to do releasable sutures, what I like to use. It's keeping the chamber formed. At the end of the case, it's very important to keep the chamber formed so you don't have hypotony. Hydrate the stroma. Now he's closing the conjunctiva, passing the needle through there and through the conjunctiva from the limbus and tying that down. And I'll do that on both sides, on the right side and on the left side, to have a nice bleb. Okay, I recommend this surgical approach for glaucoma, for all your glaucoma patients. But the key is you have to be a good surgeon to do a good technique so you have an excellent outcome. That's the key. And this is an inexpensive way of doing that. Now, here's a releasable suture technique. Okay. Pass an incision, make an incision into the cornea, and back through the cornea, back through the scleral flat. Pass it through, do 4 throws, and tie the loop down. 4 throws, like that. Boom, and then just cut it. That's the first releasable suture. You do the same thing a second time. You do the same thing a third time. So at the end of the case, once you close the conjunctiva, in the office, if you need to, you can pull a releasable suture out from over here. 1, 2, and 3 to further lower the intraocular pressure. So I like to do with my trabeculectomies with releasable sutures. After the surgery, you have to use steroids. I use it every 1 to 2 hours for about 4 weeks. Antibiotics, QID, for about 1 to 2 weeks. Sometimes, then I'll say about pulling a suture out if I need to lower the pressure. If the pressure goes up high and you want to lower the pressure, usually these patients, if they have very advanced glaucoma, you want to come down to pressure of 8 to 12. And so you can pull 1 or 2 of the stitches out as needed. Sometimes you can get an encapsulated bleb and you need to do a needling, okay, that occurs over time if it fails. You can use mitomycin C, okay. Sometimes you get a bleb that looks very ugly like this, that causes a lot of dryness. You may need to do some surgery to remove this portion of the bleb and give lubrication. You want to prevent any infection. If you see a white avascular bleb like this with mitomycin C, you may want to revise this to prevent any infection. This is the worst thing that can happen when you get an endophthalmitis, an infection like this. Then you have to give intravitreal antibiotics that can occur. But you want to try to avoid these white avascular blebs. You want to try to avoid having too much of a low pressure. That can lead to hypotony maculopathy. That can lead to loss of vision. Sometimes you can get a superciliary effusion if you have a flat bleb and low pressure. You may need to repair that. This is a revision of a bleb. This is a person with a failed trabeculectomy. I'm using a Grover spatula here in this patient. You have a flat bleb here that's failed. And I'm using a Grover spatula and I'm going through the ostium here, okay? And I'm going to pass through into the subconjunctival space with this long Grover spatula to restore the outflow. And here I'm mechanically restoring the outflow. And you'll see the Grover spatula come out into the subconjunctival space here. And I'm bluntly dissecting an opening to the scleral flap. And I'm using a tire here to give counter pressure. You can see here, this is going through the scleral flap back into the subconjunctival space. I'm opening that up. I'm using this as counter pressure through a paracentesis to restore the outflow. So if someone has a failed trabeculectomy, you can reopen it. This is one of the techniques that I'll use to reopen it. And I'll fill the eye up with BSS. Another technique is a needle revision of a bleb. And here I'm using a 25 gauge needle. I usually use 21 gauge needles now. I've numbed the eye with BSS here, and I'm going in behind the bleb in the scar tissue here. And so I'm breaking up the scar tissue, okay? And restoring the bleb, I'm going into the anterior chamber beneath the scleral flap. And this helps to restore the bleb. I do this in the operating room also. So if I want to revive a bleb that's failed, you can do that as well. Here I created a small buttonhole, but that will close up on its own because it's very vascular there. And you have lowering of the pressure and you can restore the outflow. So for neovascular glaucoma or for failed blebs, you can use glaucoma tube shunts, which I won't get into at this point, like Ahmed valve, Barvelt valves. So glaucoma filtering surgery is an excellent treatment to lower intraocular pressure for those who fail medical and laser therapy, excuse me. Glaucoma surgery must be performed meticulously, and you really got to have their techniques down. From the pre-op to the post-op period to ensure success and preservation of vision. Thank you very much. It's been a pleasure. You can email me any questions you have to dlaroche, Laroche, MD @AOL.com, and I'll be more than happy to answer any questions you have. You take care and you have a great day. I'll turn it over back to Joa and the leadership crew to discuss also further issues. Take care. Bye-bye.